All right, 60-year-old male. He's coming in with with type 2 diabetes, and he's scheduled for a TKA in 3 weeks. He's on metformin 500. Hemoglobin A1C is about 12%. What would you do? Would you proceed?
I would not. I would
Why is that?
recommend better glycemic control.
All right, why is
Due
that?
to the risks of his political diabetes that include poor wound healing, infectious risks, and those kind of things.
Wonderful. You're spot on. Spot on. All right, next one. We're going to go to your right. 55-year-old female, right knee arthroplasty, a little bit different. Takes metformin 500 BID, Lantus 20 units every morning, and A1C is 8%. Would you proceed?
What is the surgery today?
Yes. Or you're calling this patient the night before.
Yeah, I mean, I think I would proceed. I would recommend that they, for the morning surgery, typically you recommend them holding their, they stop the metformin the night before and half their normal long-acting dose of insulin for that morning. I mean, I would talk to them about probably that their risks for things that Shay said are probably a little bit higher, but I mean, it's not good control, but it's not absolutely terrible.
Robbie, do you agree with your colleague about his medication adjustments?
Yeah. Well, I might decrease the Lantus dose if we're calling the night before. Maybe decrease it to half.
You said,
Oh, yeah.
I would go ahead and continue the metformin. I see no risk of stopping or like of continuing it.
And what about the Lantus?
We could probably half that and then check it
Okay.
and kind of titrate accordingly.
Okay. So I'd like to ask these questions because, there's a little bit of variance, and so, it's an opportunity to actually learn. There's actually some nuances about how to, which medications to continue and which ones to hold. In fact, actually, for this kind of patient, you'd probably continue his metformin the morning of surgery, and then you'd bring down the Lantus to about 80%, and I'll show you data on that. All right, next one. I'll come over on
to
this
what
side.
percent?
About 80%.
8%.
All right. On this side, 62-year-old male presenting to the ER with abdominal pain, cholecystitis was the diagnosis, scheduled for a lap chole. Takes glargine, 30 units in the morning, 20 units in the evening, and exenatide. Hemoglobin A1C is 11, patient's NPO. Would you proceed? Very good. Yeah.
Oh.
Yeah.
Your cholesterol test is going right now.
Good. It's in the ER.
I would like to know when he took his last glargine, NPO, or NPO. Like when did he take his last dose of glargine? I would take a look at his labs too before I make any calls. Like what is his sugar now?
Mm-hmm.
And patient has to go. It'll go, but then
What benefits tomorrow? What would you do? You present in the ER tonight. It's probably scheduled for tomorrow.
Probably won't make that much of a difference as far as whether it goes now or tonight. I mean, his A1C is not going to change overnight. So I think you just have to focus on the acute, like current glucose. Want to avoid hypoglycemia is the big thing.
What would you do with the exenatide? How would you recommend to your surgical colleagues?
Wait, it's going now or tomorrow?
Tomorrow.
Tomorrow, I would just discontinue the exenatide. We always have IV insulin available if you really need it. Again, I would be more cautious to avoid hypoglycemia rather than like the exenatide. If you take it, it's in your system, whereas you can always give more insulin.
Good. Good. That's very much the approach that you would take. So let me just go over what we're going to go overall. I'm going to blast through a couple of these slides just because of the time. A lot of these are tables that I want you have them in your slide deck. You guys got the slide deck? Yeah. And you can reference those tables because the nuances are there, but I want to give you a big picture overview. So we're going to go through the pathophysiology of type 1 versus type 2, review some of the anti-hyperglycemic agents that we're starting to see, especially some of the new ones, some of the perioperative, intraoperative, and then hit some of the board questions. Okay? So the biggest thing is the difference between normal glucose physiology and then the pathophysiology when you get into diabetes. So in the normal state, what you have is you have a lot of glucose, your pancreas secretes insulin, that insulin then gets the blood glucose to go into the muscles and get converted into fat cells, and that's used for glucose storage. So the insulin actually gets the sugar into the muscles so that the muscles can use that for energy production. Now, back in the days before the agricultural revolution, we were in this state where we had less glucose, and when that happens, you have these stress hormones that actually get secreted, so cortisol being one of them, which you just learned from Dr. Hom. And what that does is it gets the muscles to start releasing sugar back into the blood through gluconeogenesis as well as from the liver, and then you convert some of the fats into keto acids that you can transport really to the organs that need blood sugar and energy sources really readily: brain, heart, kidneys. Okay. So now when you look at the pathophysiology, the prototypical pathophysiology is actually type 1 diabetes, and that's when you basically have a pancreas that's destroyed. And so when you destroy the pancreatic beta cells, what happens is you have a huge amount of non-functioning or non-existent insulin. And that's what creates the high blood sugar, because you no longer have a mechanism to get the sugar back into the muscles to be able to be used. So essentially what happens is the body thinks that it's in a starving state, and it starts to just go into glycogenolysis, and then you start to break down all your fat cells in order to produce ketones, because the body thinks that it's starving. And so it basically has unimposed ketogenesis, and that causes more hyperglycemia because the fat's being broken down and the liver's producing sugar by gluconeogenesis. And what ends up happening because of the high level of blood sugar in the blood, you basically get an osmotic diuresis and volume depletion. So these patients, the classic type 1 diabetic looks skinny because they basically have lost all their fat cells. And then they come in diabetic coma because the osmotic diuresis has essentially shrunk their glial cells. And so they start to have cognitive dysfunction on that. Then when you have unopposed ketogenesis is a keto acid. So basically you have acidemia, and always with acidemia, if you actually work out the charges, anytime you have acidemia in the blood, you will also have hyperkalemia. And so the two go hand in hand. So you can either work out the ions, or you can just memorize that acidemia equals hyperkalemia. And so that's really the big pathophysiological issues with type 1 diabetes. So when essentially I wanted to use this diagram to highlight the fact that your adipose tissue in the starving state basically gets broken down into keto acids that then can be used by other organs. And so the big thing about type 1 diabetics is that they have to be exposed to some sort of insulin to shut this process down, to basically stop them from going into ketoacidosis. So we always talk about, hyperglycemic ketoacidosis. As long as a type 1 diabetic's exposed to insulin, they won't transition into ketoacidosis. Okay, that's the big takeaway point. So now let's cross-compare that to type 2 diabetes. With type 2 diabetes, it's basically that the patients are getting insulin resistant. So you need more and more insulin to actually bring the blood sugar into the cells. So when you have more insulin just floating around in the blood to get the sugar in, for a long period of time, your blood sugars will be normal because the high amount of insulin is getting them into the muscle. But you have so much insulin that actually gets glucose to store into fat that you start to build up fat cells. And that's why the type 2 diabetic is obese, central obesity. It's because they're storing all this fat, thinking that they're in basically a starved state again. And so here you also get the hyperglycemia that can eventually get you osmotic diuresis. This is hyperglycemic hyperosmolar crisis. And that also causes this same sort of diabetic brain coma state if it gets into its extreme form. So this is the table that's the big takeaway between HHS and ketoacidosis. So this is what you're going to see in your type 1 diabetics. This is mostly what you're going to see in your type 2. I've put the ones that are going to be the biggest differences and the most marked differences in red, Because these are the differences that they're going to highlight on your board exam, and they're going to make you distinguish on your boards. Okay? So the pH normally with ketoacidosis is when you see them become very, very acidotic, whereas in HHS, they don't. The blood glucose, though, in HHS is markedly elevated in the patient compared to ketoacidosis. So patients with type 1 diabetes and ketoacidosis, their blood sugars are going to be in the mid-300s. Your HHS patient's going to have blood sugars in the 600s, 700s, thousands even, okay? The serum osmolality, so again, if you work out your charges, and we won't do the math right now, but it's markedly elevated in hyperglycemic hyperosmolar crisis, versus the osmolality is basically within normal limits in your ketoacidosis patient. Just as we talked about in the name, the ketoacidotic patient will have elevated ketones, but that's going to be absent in the hyperosmolar patient. And then, of course, you're going to have an anion gap with ketoacidosis. The anion gap is plus or minus in hyperosmolar crisis, but for your board exams, just think of this as absent, all right? So mainly you see HHS in your type 2 diabetics, and you see your ketoacidosis in your type 1 diabetics. Any questions on that? That's really just a table that you need to memorize right before you take your IT or your boards. Okay. All right, so going back to your management of DKA, this is like the main algorithm of the DKA management. The biggest thing that I want to point out here is that with DKA and HHS, you start a insulin drip, okay? And the insulin drips are spelled out by these algorithms. But with DKA, the only time that you stop the drip is when you see the anion gap close. Only then. You continue to check your electrolyte panel up until the anion gap closes. That's the distinction, though, in HHS, is that you stop your insulin drip once you get it below 300. Because you're not going to go back and forth in transition. You're going to stay pretty stable if you can keep the blood sugars under 300. Again, when you're running an insulin drip, the biggest thing to remember in the management of these patients is when you give insulin, potassium comes into the cell alongside glucose, right? It's a co-transporter. And so you always have to think about supplementing potassium when you're giving insulin and an insulin infusion. Okay, so you have to keep very, very close track of the potassium. So these are all your anti-hyperglycemic agents, okay? So the ones on top, such as metformin, are the ones that classically are known to cause lactic acidosis. Now, let me make one comment about lactic acidosis. It is based on case reports only. There's 7 case reports of lactic acidosis, and they only occur in patients with either individualized chronic liver disease or a combination of acute kidney injury and chronic liver disease. So in a patient that you're bringing into the OR, if you think that the patient, 1, has an underlying liver or kidney issue, or if you think in the middle of the case that there's enough blood loss that can cause acute kidney injury or can cause shock liver, those are the patients that you're thinking about holding their metformin. These are patients like, liver resections, liver transplants. These are those kinds of patients. For your normal orthopedic procedure that isn't going to bleed 6 liters or hernia operation, no, it's probably safe to continue your metformin. You got your sulfonylureas, and these are the drugs that are going to cause you intraoperative hypoglycemia. And that's because if you keep them running on the day of surgery, their half-lives are so long that they're going to get hypoglycemic in the middle of it. And then all the other drugs that are given for anti-hyperglycemic agents, they tend to cause delayed gastric emptying, and so they're aspiration risk drugs. So you just got to think about that. With a patient with major diabetes, they tend to have slow gastric motility. They tend to have, gastric neuropathology. So their emptying time of their stomachs tend to be decreased, and so they're at higher risk of aspirating no matter what. All right, let's look at the insulin agents. So your fast-acting agents are your Lispro, Aspart, and glucilline. And those are basically an onset time of 15 minutes. Your regular insulin, which you get in the OR, which you infuse through the IV, is about 30 to 60 minute onset time. Your GLAR genes are a lot longer, 2 to 4 hours, and the duration is about 20 to 24 hours. So this is what they consider your basal insulin levels, okay? Versus the Lispro and the Aspart are prandial insulin usage. So going back to your review for step 1, the way to remember the length of time for insulin is LARN to lug your insulin. So Lispro, Aspart, regular, NPH, lente, ultralente, and glargine in terms of time. Okay, so glargine is the longest, most basal insulin. All right, so that's going back to the mnemonics in, what's it called, first aid? No, I'm getting away from it, so it's very neat. So, as Shay was talking about, hyperglycemia causes issues in terms of surgical wound healing in patients. So there's multiple roads that you get hyperglycemic in the OR. One is that just based on their pathophysiology of insulin resistance, and that's from diabetes, obesity, and even septic patients do this. There's also a endocrine response. This is from the stress hormones like cortisol that are being secreted. And then you can also get it from like destrose fluids. Even the volatile agents will cause that. And of course, steroids increase your hyperglycemia in the OR. Now, the complications of hyperglycemia are many. There's a lot of only retrospective studies. There's not very good prospective studies. But they all kind of concentrate on a couple of things. One is surgical site infection rates. Second is pneumonia. And 2 is UTI. So these are all like kind of like an infection conglomerate that hyperglycemia tends to exacerbate. So you got to think about that in your patients that you're bringing into the OR with hemoglobin A1Cs that are greater than 8 and greater than 9, is that it does increase the chance of wound healing problems and surgical site infection rates. So if you or the surgeon or the team is concerned about the surgical site infection rates, it's a good reason to control your blood sugars tightly. I'm going to skip that slide. This is a slide that I don't want to walk through because of time, but it's a very, very elegant animal experiment where they actually took rats and they converted a certain percentage of rats into diabetics and kept another control arm as normal. And then they split the diabetic rats into 2 arms where they did a short-acting insulin therapy and a long-acting insulin therapy prior to surgery. And basically, I want to go straight to the data, is that both when you start short-term insulin or long-term insulin, the bacterial load in the actual tissue sample after they euthanized these rats and after they injected Staph aureus was lower no matter if you did it from a long-term perspective or a short-term perspective. So in terms of surgical site infections, it's super, like as anesthesiologists, we can actually make a difference in terms of surgical site infection rates because if the blood sugar is high, we can control it with insulin in the operating room, okay? So that's like a major contribution that we can do to actual surgical outcomes. And these are one of these things that are highly measured in national databases, Leapfrog, etc. When you have a diabetic patient, it's important to actually look at their hemoglobin A1C. They should be getting hemoglobin A1Cs every 3 months, and so it's a good idea to actually look to the hemoglobin A1C to just see what are they going to do in the operating room in the perioperative space. Patients who have the hemoglobin A1C greater than 8%, they tend to be hyperglycemic in the OR, and then they for sure tend to be hyperglycemic in the perioperative space. And so you can identify these patients ahead of time, you can control their glucose intraoperatively, or at least, in the least, you can prepare the surgical team to prepare to control their glucose in the postoperative period. And this is the data from Gustafson and colleagues. It's an older paper, 2009, that actually shows its difference between high hemoglobin A1Cs and low hemoglobin A1Cs and how it affects perioperative hyperglycemia. So I'll go to this about going back. Should I delay my patient's surgery because of the glycemic event? So if it's elective surgery, as we talked about, it's probably a good idea to try to get better control of your glucose if the outcomes of that high glucose are going to be negative. So for example, in that knee replacement, you don't want the newly implanted knee to get infected. And so it's probably a good thing to wait. If it's semi-urgent or urgent, you're better off just controlling the glucose intraoperatively because we're anesthesiologists, we control everything of physiology. We might as well do it here too, okay? Any questions on that? All right, so these are the sections of tables, okay? These are the tables to just either snip out and keep in your notebook or go back and review. And it's basically what to do with these medications on the day before, the day of surgery, and intraoperatively. So for the most part, on the day of surgery, you're going to hold all your insulin secretagogues, your SLG2 inhibitors, your pioglitazone, rosiglitazone, those drugs. Metformin, again, is a plus or minus, okay? It's based on, it's really based on the fact if you think that they're going to be in acute kidney injury or if they've got liver disease where they can't metabolize the lactic acid, okay? That's where you're going to get into trouble. And then there's these new drugs that are DPP4 inhibitors, and those are the ones. Those are like the gliptin drugs. They end in gliptin. Those are the ones that you can have the patients take on the day of surgery. Then let's talk about the insulin adjustments. So the day before surgery, they mostly can take their long-acting insulins, and what you want to do is on the morning of surgery and the day before, you want to reduce their PM glargine by about 80%. Okay, and I'll show you some data that even on the morning of surgery, it's good to give their basal insulin. Just give their basal insulin at 80% the dose.
Where did the 50% number come from?
Yeah, so 50% used to be, it was an old management algorithm. And what ends up happening with the 50% is that most of the patients are coming into the pre-op area hyperglycemic. And so they redid it and they did a new study where they put them into arms at 50%, 60%, 70%, 80%, and 100, and I'll show you data for that. And they looked at the pre-op capillary finger stick, and 80% was the place where you got good control, but not that many hypoglycemic events. This is exactly that chart that I'm talking about. So this is exactly what they did. They showed how much percent of glargine taken, and then this is the dot plot of where their glucose came. And so if you see that when they took 100% of their glargine, there was a good number of patients that had hypoglycemic events. When they took about 80%, there was only this one outlier here that was essentially under the hypoglycemic threshold. Whereas anything below that, you had all these patients that were hyperglycemic coming into the preoperative area. So it's probably a good idea to take about 80% of the glargine. Okay. Now, what do you do on the day of surgery if they are hyperglycemic? So if they're awake before they're under general anesthesia, you can actually give them a sub-Q short-acting insulin, so Lispro or Aspart. And this is the new table about what to use depending on if their blood sugars. So the blood sugars are written on this side. So usually we say, let's treat it above 200, okay? And if they're insulin sensitive, you can give them 2 or 3 units of insulin and then check that blood glucose in 15 minutes or half an hour and make sure that they're not getting hypoglycemic. And if they're insulin resistant, then you titrate it up. All right, so this is like a good table to have of like, all right, how many units should I give because the patient's blood sugar is like 240 before I go into the OR. All right, so if you've got your type 1 diabetic, all right, you're going to maintain their basal insulin dose. Your NPH you reduce by about 50%. And then for the type 1s, they always need an exposure to insulin. Usually the basal insulin is enough exposure to keep them from transitioning into ketoacidosis. But you should anticipate that you're going to be using an insulin drip on these patients. If they're going under elective surgery at the surgery center or places like that, you want to move their cases to the first case start of the day so that you can give the glargine that they would normally use. That's going to keep them from transitioning into ketoacidosis. And then they eat as the first patient that eats by the time they get out of the procedure. So by that time, they won't get hypoglycemic. Now, what if they have an insulin pump, okay? If they've got an insulin pump sitting, what you want to do is you want to make sure that they continue their basal infusion rate. And just, you could reduce it to 80% as you normally would. But these diabetic patients, they know how to operate their insulin pumps. So just trust them. You just tell them, like, can you reduce your basal insulin infusion to about 80% the dose? And just let them continue it, okay? If it's in the surgical field, what you have to do is you have to get them to DC their pump and then administer 80% of their same basal dose by a sub-Q needle insertion. Okay. So that's the way that you work with insulin pumps. Of course, with the type 2 diabetics, you hold the oral hypoglycemic and the non-insulin injectables, and then you also basically hold their prandial insulin bolus, like what they would normally take 3 times a day with their meals. All right, and so your basal insulin, of course, now it's 80%, and NPH you're reducing to 50% the dose. I'm going to use this big roadmap to show you just a little bit about the postoperative period. So in the intraoperative period, we are thinking that we're going to use, as anesthesiologists, insulin infusions when we need to control the blood sugars, okay? In the postoperative period, you know how like the surgical services always put these patients on sliding scales, okay? Sliding scales totally inappropriate nowadays, okay? Everybody gets off, when they come into the hospital, they get off their oral medications, and they get put on this regimen called a basal bolus regimen, okay? And that's because it's much more effective and pro-acting compared to the sliding scale. Sliding scale insulin is always reactive. It's always, you're waiting until the blood sugars get above a certain level, and then you're treating it. It gets above a certain level, you treat it. You're always behind the 8 ball. With a little bit of a basal level of insulin, you're going to be ahead of the ballgame, and you're just making little adjustments with little boluses afterwards. So I'm going to get to that actually. I'm going to skip that. I'm going to skip these charts. And I think I'll show you, give me 1 second, I will show you that the basal bolus in a moment. So this is a thing that's come up several times now through our QI reports. You know, like the QI things that you fill out at the end of the day. Insulin is a super dangerous drug, okay? It's one of these drugs that can actually cause death and you don't even know about it because your patient's anesthetized and totally vulnerable. So there's a couple of very, very key safety things that I want to get across to you guys going into the OR with insulin, okay? So one is always use extreme caution and conservatism with insulin, okay? Because if you get, especially these older patients who are above 70, when they get hypoglycemic, that's when they have cardiac and neurological issues, okay? And you might miss it for hours, okay? The second is that for the outpatient procedures, you want to use short acting sub-Q insulin when they're awake, okay? On the longer extensive surgeries in Reagan, when you can, and you are going to be putting in an arterial line, that's the time to use insulin infusions, okay? Third is if you're going to use an insulin infusion, hook it up to a dedicated line. So if you're going to put an extra ID in and put an extra 20, or you have an existing 20, make that the infusion line. Run it on a carrier and put the insulin on that, because you don't want to push a med and bolus insulin in that line, because all of a sudden you might just find that your blood sugars are in the 40s without even realizing it. This is a big takeaway point. If it's in a non-emergent situation, that is emergent being acute hyperkalemia showing EKG changes, always use pharmacy diluted regular insulin. The ones that come in the bag from the pharmacy come at 1 unit per mil. You won't make mistakes on that. We've already seen just in the last year the number of dilution errors with insulin, because people get the 100 units per ml from the pharmacy and then they double dilute it. There have been a whole host of hypoglycemic events because of this. So use only pharmacy diluted. The arterial line is still the gold standard for checking blood sugar on your point of care device. We're taking an arterial blood sample and checking on a finger stick glucose, all right? But that's changing, and I'll show you a little bit of data. And if you're actively titrating insulin drips in the OR, check them every 30 minutes to an hour, especially like if you're making a change, if you're going up on the drip, you're giving a bolus, check your blood sugar off the arterial line within 30 minutes. If you are running an infusion at a constant rate, check it every hour, okay? Those are the big safety things. And then there's no harm in taking multiple measurements when a patient's having an insulin drip run. This is the table that you want to use when you're titrating your insulin infusions, okay? So I'll just leave that for you to reference. This is basically a Boltzmann plot that basically shows two references. So this is basically your capillary glucose measurement compared to your arterial line. And what it's showing is the newer glucometers are starting to get pretty accurate compared to the arterial line. The one exception is when you're under general anesthesia on pressors. Because when you have these patients on pressors, what ends up happening is they have poor perfusion, and so your capillaries actually misread that. So in both the hypoglycemic end and the hyperglycemic end, you tend to get erroneous readings. All right? So that's when you need to be careful. Right? So if you think the patient is bordering on the hypoglycemic line, you're better off getting an arterial stick. Okay? So your basal bolus method for the post-op care, basically the big takeaway is that it's shown to decrease your wound infection rate and your total complication rate compared to sliding scale. So it's better in general. So the big thing about basal bolus regimens is this. This is how to basically calculate how much you're going to start with basal, and then this is your bolus and your correction scale. All right. So basically, if you have an NPO patient, you're going to calculate your total daily dose from here and give half of it as a basal, and then give the rest during corrections every time they're at a certain time period, either Q4 or Q6 hours. If they're eating, then you're going to give 1/2 of what you calculate as the total daily dose at their meal times. And then you use this table as the correction for if they're still hyperglycemic after their meal. So basically, what you need to do is you need to inform your surgical colleagues if a patient's really, really hyperglycemic that they need to put these patients on a basal bolus regimen. If they don't know how to do that, tell them to contact the endocrine service for a hyperglycemia service.
Is this an epic net?
That's a good question. I think
You can just type sliding scale and it pops up.
Yeah, that's a good question. I don't know that. I should check that. But that's a. If it's not, we should put that in there because that's what the entire endocrinology department uses. So this is a big thing for your boards about how to control glucose in the ICU. And this is data been around since 2009. It's basically the nice sugar trial that basically shows that you want to in critically ill patients, you want to maintain a blood glucose between 140 and 180. You don't want to be totally aggressive because it increases the mortality rate. And this is basically the big New England Journal of Medicine paper back in 2009 that basically showed the intensive group has higher mortality than the conventional group. All right. So that's the big thing. Is now 140 to 180 is the range in vogue. So this is essentially a summary of that. And most of the societies are basically converging on that across the world. Right? So let's go and try some questions, and then hopefully we'll have time. Does this end at 5?
Yeah.
Jeez. Okay.
Dr. Chan was like really
Was
aggressive
on it.
on it today about it.
Okay.
She's always on it, I guess.
So let's. Did you guys log in? Everybody kind of logged in. There's only 4. How many? 1, 2, 3, 4, 6, 8. Any more people?
Coming.
Internet's slow.
Oh, is it?
She's lazy.
All right, let's get started. Which of the following insulin preparations has the fastest onset of action if administered sub-Q? Oh, how come it's not showing my?
There's one here.
Is there a way to convert it back to the other screen?
He's watching a movie.
Are you watching a movie? Is there a way to convert it back to my web page here? I want to bounce back and forth. All right, let's see how we did in the meantime. So actually, everybody got it right in terms of Larmier, Lug, Lispro. Perfect. Yeah, I wanted to show this one. Should I?
Change this one.
Usually, they used to give me like an hour and a half to do these 2 sections. But
It's about along the same period of time.
yeah. All right, so let's go to the next one. You guys got it all right. Okay. Which of the following is true regarding the management of decay? I figured that doing the board's questions would be helpful, right? Okay. We might have to go back and do Carcinoid. I don't know when. Maybe we'll do an ad hoc over beers or something like that. Okay, perfect. So the big takeaway point in this is that you need potassium when you're giving an insulin infusion. So that's great. The big ones that I wanted to, of the other answer choices. So why is it not B? Can someone?
Yeah, for the anti.
Right, for ketoacidosis, right, for TKA, but you can use it until the blood sugar is less than 300 only in HSS. All right, so let's go to the next one. All right, which of the following is true about HHS except? All right, let's see how we get. Commit to an answer. Okay, so this one has a spread, okay? So, which HSS, so the actual answer is D. It's a lower mortality than compared to DKA. Actually, it has a higher mortality than DKA. So that's one of the big things about this thing. So, HHS occurs in type 2 diabetics versus DKA occurring in type 1s, okay? Serum ketones are present only in DKA, but you may or may not see it in HSS, and that's because it all depends on how starved the body sees itself. Okay, and if you go back to that table, that's where you'll see some of that answer. I think everybody figured out that the serum glucose is higher in HSS than DKA, and then occurs more commonly in the elderly, and that's because you see it in type 2 diabetics versus type 1. So that's why it's more common in that group. All right, let's go to the next one. So this one, you just saw the data. We just kind of reiterated, according to the 2012 ADA recommendations, what you want to maintain the finger stick in the ICU. I'm sure everybody kind of got this right. So there's just a couple people that got it at 120, and the main takeaway from the night sugar trial is 140 to 180. Okay, that's like the big takeaway from that trial. All right, next one. So admission, 17-year-old admission, glucose is 512, pH is 7.2, on an insulin drip. Which study is most important prior to inducing her in the OR? All right, let's see. Potassium, exactly. Because if they get too hypokalemic, then they could have cardiac abnormalities when you induce them. Very good. All right, next one. Insulinoma. ABG, while they were manipulating the tumor, blood glucose is 45. What would you give to treat the hypoglycemia while you're trying to get another IV? It's a little bit of a tricky question. Commit. There we go, let's try it. Okay, so almost everybody got it right in terms of glucagon. epinephrine, so one glucagon can be given intramuscularly. So if you don't have an IV, you can give it intramuscularly and work on it. Epinephrine, it's not going to make the adrenal glands secrete more sugar in time because it's a short-acting drug, so it won't do that. The other one that's kind of confusing is dioxide. That's a drug that's used in the outpatient setting for insulinomas. So we don't use that drug. All right, I think that's the questions for the boards. I will try to see if I can work with Dr. Turner and Jack if we can do carcinoid. It's pretty short. Most of the things are in the notes for carcinoid. The big takeaway on carcinoid syndrome is the two things to pay attention to is octreotide, octreotide, octreotide. That's the treatment when you think of carcinoid. 5-HIAA is the diagnostic, and then they have right-sided heart symptoms. Okay, and I have a flow chart there of why you see it on the right side versus the left. Those are the things to pay attention to. The other thing that I want you to pay attention to for your boards is there's a table about which ones. Which symptoms show up the most with frequency. They always ask that on the ITE. They try to ask you between flushing and bronchospasm. And if you know the percentages in that table, you will never get that question wrong. All right? Those are the big ones in carcinoid. But I'll try to find a time when we could go through carcinoid. It'll only take 10 or 15 minutes. All right?
Thank you.
Okay.
Yeah.